All right, fantastic. It's so exciting to be a part of this panel today. And so today I'll be talking about hernia repair in the obese patient. Do we really need to say no? My disclosures are not relevant to this talk, and I have none currently, which is great. So fantastic. So let's talk about the future of hernia care. Certainly, obesity rates by state are increasing, and by 2030, about 60% of the states will have people that are obese. This paper was published in the New England Journal of Medicine in 2019. And I think what is most important is that nearly 1 in 4 adults will have severe obesity, but we are all not getting obese at the same rate. So 1 in 2 people that are either female, non-Hispanic Black adults or low-income adults will have severe obesity. So let's start with a case. This is a 45-year-old female that presents with a symptomatic incisional hernia. Her surgical history is a C-section through a vertical midline incision. She's had a cholecystectomy, an appy, and a tubal ligation. She's a non-smoker. Her BMI is 50. She's a diabetic, but her HbA1c is less than 7, and she's in chronic pain. So I'm going to play her scan here. She's adamantly refusing bariatric surgery. You bring it up and she starts crying. She says she can do this on her own, and she's lost 40 pounds of weight already. She tried a GLP-1 medication, and unfortunately her insurance no longer covers it, so she cannot afford it. Oh, and the kicker is she's had 2 admissions in the past 3 months for obstructions that require an NG tube placement. So what is our current practice? I think it is great, and a lot of people are doing a good job of prehabilitation prior to elective ventral hernia repair. We recommend weight loss, and a lot of people have a wide spectrum of BMI cutoffs for certain hernia repairs. But I think the answer is there are limitations to BMIs in certain different hernia disease, and not all hernias are equal. So somebody that has a massive loss of domain hernia is certainly different than somebody that has a higher BMI that has some sort of omental necrosis or infection, and sometimes those smaller hernias can wait as well. I also think that this conversation is coming up a little bit more common. Certainly not all fat distributions are equal, and we talk about these apple type or visceral fat as well as pear types, and maybe it's okay to fix a hernia if you have a pear type abdomen, but if you're an apple type, maybe we shouldn't. And this study was actually published very recently in JAMA of 2024 that chose body composition to predict frailty. And I think a lot of times we use visceral adiposity as a marker of morbidity in hernia repairs. So what they looked at is skeletal muscle area, volume, and density. They look at subcutaneous adipose area and volume, as well as visceral adipose area and volume. And what they found was pretty interesting. Not shockingly, if you had great muscle quality and quantity, you were less frail. And I think we probably expected the same outcomes depending on the positive obesity or adiposity that you have. But that is not what they found. Actually, the distribution of your adiposity was not associated with frailty. So do we have recommendations from a society? And I happen to be the chair of the Practice Advisory Committee, and I would say this was a pretty liberal recommendation about how to care for obese patients. We said a BMI greater than 45 to 50 has been considered prohibitive for elective hernia repairs, with many surgeons using lower BMI thresholds. And so the answer is why are we saying no? And I think we have legitimate reasons to say no. I think we've all seen a patient that maybe had a higher BMI. They develop a horrible wound complication. They now have a recurrence that you have to deal with. There's mesh that needs to come out. And it becomes this vicious cycle of a hernia disease in an unoptimized patient. And I think there is a lot of evidence to support that statement. And when we looked at this published study published by Testaldi in 2019, you certainly see a linear correlation of wound morbidity when people have open ventral hernia repairs. And this other study published in Surgery in 2017 certainly shows that when your BMI is higher, your risk of any complication is higher. But I think it's important to note that if you have a BMI of 40 to 50, your complication profile, your risk is 14.3%, which in general is not terrible. So I think as we talk about preoperative optimization, we need to understand the effects that have on the hernia care that we provide across the country. And this study was published in Surgical Endoscopy last year, and it looked at how our pre-optimization strict cutoffs affect how we care for patients. And what they found is that when you are setting these strict optimization criteria before you offer people hernia repairs, just as that study showed in the New England Journal of Medicine, you're more likely to not fix females, you're more likely to create socioeconomic disparities in hernia care, and you're addressing different racial populations. So if you have strict cutoffs, you are creating disparity in care. So I think the important thing is, how do we get to yes? We really need to negotiate an agreement without giving in. And I think in general, we want to get these people to have their hernia fixed, but we need to make sure that we are doing the appropriate things to provide care for them. And with any hernia repair, our goals are about the same. We want to minimize morbidity. We want to make sure our recurrence rates are very, very low, and we want to improve our quality of life. So how do we get there? And I think the first answer is it safe to say yes to these patients? And I think what we're starting to see now is maybe there's some things that are more predictive of recurrences than BMI. And so this study published in Surgery in 2020 looked at the unadjusted 5-year cumulative incidence of recurrence after ventral hernia repair. And you can see if your BMI was greater than 35, you had an increased incidence or increased risk of 6.8. But if you had a postoperative surgical site occurrence, it was 32.3. And this held true when they did a regression analysis, including factors that were associated with more hernia relations. So the answer is what about if we can offer them a different approach? And so you look at this study, and it showed that in general, your morbidity is going to be much higher if you're on this extreme spectrums of weight. So that's serious morbidity as well as readmission. However, when they adjusted this and looked at an open versus a laparoscopic approach, actually those things that were significant when that open repair was offered, they are no longer significant when you can offer them an MIS repair. So this study was also looked at kind of some of the hernia-specific or maybe procedural-specific risk factors associated with early complications in ventral hernia repair. And what you can see is your BMI is right at the 1, and all of these other things are things that we need to consider before we say yes to these patients. What is their distress communities index? Are they on anticoagulants? What other medical comorbidities do they have? Let's talk about hernia characteristics. Are they big? Are they lateral? Are they recurrent? Is there more mesh? And then, how are we actually fixing these? And I think what we're seeing now is that hernia disease is different, and how we care for our patients needs to be different. And so I think the answer is if you are going to say yes because you can provide an MIS repair. So this study was published by Kudzi et al. That looked at, is it safe to provide a ventral hernia repair minimally invasively to class 3, so a BMI greater than 40 patients. And what you can see when these were compared to a non-obese cohort in unmatched groups, their short-term postoperative complications, not shockingly, there was a higher amount of clebido-dindo grade 2 class complications, as well as a higher amount of cellulitis. However, when they controlled for hernia disease and patient comorbidities, they were no longer statistically significant. So certainly these are is an option. We also looked at this at Penn State, and we looked at robotic ventral hernia repairs in patients from 2013 to 2022, and we separated those based on 3 different BMI classes, as you can see here. We looked at perioperative outcomes, including intraoperative complications, as well as postoperative outcomes, including SSO, SSI, and recurrence. What we found that certainly as you are a little bit heavier, your risk of postoperative complications was statistically significant. But when we looked at the complication was, a lot of these were SSOs, so seromas, oftentimes which may not be clinically significant. When we performed our multivariate regression analysis, you can see that yes, as your BMI goes up, you are more likely to have a complication. But again, the biggest driver of an SSO was not the BMI of the patient, but the hernia width. And so maybe it is actually safe to say yes. And this systematic review and meta-analysis did show that irrespective of BMI, even if you were greater than 40, your risk of seroma was no different if you were a BMI of 30 to 40, and also your risk of recurrence rate was no different based on BMIs 30 to 40. So I think my take-home points are this, is care for patients with a BMI greater than 35, 40, and maybe even 50 is going to be standard for us if it's not now. I think pre-operative optimization is very important, but we have to understand the limits in our patient population and our specific patients. If you can offer an MIS repair, I think that is great and can be offered safely to higher BMI patients. But again, it's very important that we tailor all of the care to the patient's specific hernia and their specific comorbidities. Thank you very much.